Lessons from the Cataract Coach. Thanks for the kind invitation to speak to you today. I'll teach you what I've learned from more than 1,000 teaching videos, with a new one every day, 26,000 subscribers, and 8 million views. Keep in mind, you're at the beginning of this learning curve of cataract surgery, and note that the scale here is logarithmic. So at the end of your residency, you're about halfway up that curve. So you need to keep working hard to climb even farther. CataractCoach.com. Which career path will you choose? You want to be an expert surgeon or a competent surgeon? I first learned about this from my friend Professor Milton Yogi from Sao Paulo, Brazil. So we're going to play a routine case here in the background, but we're really focusing on this graph in the bottom right corner. So which career path do you choose? We have 3 lines there. The blue is the dropout line. The red is the competent surgeon, and then the green there is the expert surgeon. And there's a big difference. You see, the dropout surgeon, just within a couple of years, hits that frustration barrier in trying to learn surgery. The surgical skill is not easy to develop, and this doctor just quits, drops out, switches to a different specialty, goes into business, doesn't practice medicine, something different. But let's say you get past the frustration barrier. You've got 2 choices here. You've got the competent surgeon who is okay. And this is a surgeon who, whatever was learned in residency, will continue to do for the rest of the career. And this is a stagnant option because the skills don't really advance, new techniques aren't learned, new skills are not developed. And this is a surgeon who, yes, technically is competent. That's a good enough surgeon. But that surgeon's stuck in that zone of mediocrity. And then finally, you've got the expert surgeon who continues to learn, advances techniques, learns about new technology, and continues to get something from every single surgery. And every year, even 10, 20, or more years after training, continues to learn more and more. So if you look now, that surgeon has passed what's called the passion barrier. So gone past just being a competent surgeon, but having a passion for his or her craft, wanting to learn more, wanting to be better, give better options for the patient, takes pride in his or her work, and wants to truly give the highest possible level of surgical care to his or her patients. So well past the zone of mediocrity. Now, if you look at the top here, we see the different zones of time, 5 year, 10 year, 15 years, and beyond. The first 5 years, the blue block there that's what you're learning during your residency training, and you learn a lot. But even your first 5 years in practice, that orange zone, you'll learn even more. And then, after 10 years of ophthalmology, you'll really start enjoying the tough cases. You'll look for the challenging ones. You'll ask your colleagues who aren't as driven to please send over the difficult cases. And it'll be a source of pride for you. And you'll learn so much more, even though your training was 10 years ago. And then finally, the green zone there, you'll be in the master of surgery. This is where you're truly an expert. You still continue to learn. You still advance your techniques. You still move on to learn new technologies that come down the road. And you really aim to make every single case as perfect as possible. You take pride in your work. And this is the best phase because you truly enjoy your craft. There's no fear there. There's no worries about complications because whatever happens, you know you're going to handle it. You'll always give the patient your best. You'll do what's best for the patient. And the patient will have a fantastic outcome. So now in the background, as you watch me do this routine cataract case, which went very quickly and very beautifully, but most importantly, very exactingly. That's the exact rhexis that I want. That's the exact incision that I want. The lens centration is perfect. We'll put a little bit of medicine in the eye, a little triamcinolone, seal up the incisions, call this a day. This patient had a beautiful outcome, and more importantly, I loved doing it. Thank you for watching. CataractCoach.com. Cataract surgery lessons from Kyoto, Japan. I was there recently for some business development, also to learn about how surgeons there operate, and to give a lecture at a well-known university. And I want to bring back some of those lessons to you. I think number one for me was perfecting a skill takes time. Nothing's built overnight. So when you see these beautiful structures here in Kyoto, these were built over the course of hundreds of years. So for cataract surgery skills, be patient, but more importantly, be persistent. Put in the effort every week to always get better and better. And so that persistence is what's going to help you truly perfect your skill. And that takes time, usually years. You can't be an amazing cataract surgeon if you've done less than 1,000 cases. Number two is constant improvement, always trying to get better. The concept of Kaizen. Every day that you operate, what can you learn from this case to become better and better? You have to keep advancing your skills. Remember, if you just become 1% better a week, in less than 2 years, you are twice as good as you are today. So it's that drive and determination, that passion to make sure that you are always constantly improving your skills. Video your surgeries, watch the footage, say, what can I do better? Number three, people are more similar than different. I could have showed you a surgery video of some cataract surgeons I witnessed there in Kyoto, but they operate very similar to we do. It's almost the same. And I think overall, worldwide, people are more similar than they are different. And that applies to people as well as their cataract surgery skills and the way they approach things. There's a commonness to humankind, and I think that's very special. So people, certainly, more similar than different. There is beauty in imperfection, the concept of wabi-sabi. Now, we're used to seeing things that are perfectly symmetric and it's very pleasing to the eye, but slight imperfection actually has a beauty as well. So these are all perfectly lined up and they're still quite beautiful. Same applies to our surgeries. We're not machines. When you make that capsule or that incision, it's not always going to be exactly perfect. And that's okay. The patients can still have a beautiful visual outcome with no effect on their vision. But we have to accept that there is variability. Number five, inner peace is really required for best performance. If you're stressed out, you have a lot on your mind, you're not able to perform your best in the operating room. So it's important that you achieve that inner peace. Sometimes you can't resolve certain issues, so you either have to accept them, compartmentalize them, whatever it takes to achieve enough inner peace for you to perform at your best in the operating room. And that means, of course, giving patients the best visual outcome. They get the best results when you have that peace. Number six, there's a finite lifespan for all. There's impermanence. When I saw these beautiful fall colors towards the end of my trip, they started to change and the leaves started to wither away. And this is kind of the nature of everything in life. There's a finite lifespan for all, including us and including our surgical careers. So do an incredible job, make a huge impact, and leave a legacy that'll live on, knowing that your career actually does have an end date, and so does life. So the trip for me to Japan was absolutely amazing. I had such great lessons. We'll show you some of the videos of surgeries in the very near future. But I want you to take these lessons and use that as a great start to 2020. And I want to wish you a successful, prosperous, and happy new year. Welcome 2020. CataractCoach.com, we are celebrating 500 posts in a row for 500 days. And to celebrate that, I want to give some great advice to the young ophthalmologist to maximize your career success. And the first bit of advice, as you can tell by doing 500 of these posts in a row, is you've got to work hard, very hard. Remember, luck isn't just chance. Luck's created. The harder you work, the luckier you'll get. And that just means that nothing comes from just luck. It's all about the hard work. And you can work much harder than you think. And the more you work, the more you'll achieve. So keep that in mind. Some surgeons say, well, I'm training at a program that's not so great, or I'm here in this country or another place, and I don't have access. It's the horse, not the track, that wins the race. A great horse can race on any track. So yes, there are advantages to training at one program over another. But with enough hard work and determination and self-learning, like watching these videos, using other online resources, making use of colleagues and more senior doctors in your community, you can certainly learn just about anywhere. And that's a very important thing, especially when you meet more senior doctors who are willing to give young doctors a chance. And I think that's a very important thing. You'll have to be able to learn from everyone. Even now, I can learn something from any person I meet. And you got to keep that in mind. So even if you meet a surgeon who does things differently than you do, what you think is an older technique, keep an open mind. You may learn something. Maybe you can amalgamate those techniques into developing something new. There are always going to be some naysayers, some people who are haters. That's okay. You can ignore them. Even today, I get posts as comments on CataractCoach that are absolutely terrible. But this is because people are insecure and they project that. So you ignore the haters. Again, keep up with new techniques and technologies. This is very important. The way you operate now, the way I do surgery now, is not the same way that I'm going to do it in 5 or 10 years. Things are going to change. Things are going to evolve. If you just look at advances in certain fields, in corneal surgery, DSEC, DMEC, DULC, these things didn't exist. Cross-linking didn't exist just a decade ago. If we look at retina surgery, anti-VEGF medicines, OCT angiography, small gauge vitrectomy, these things didn't exist at all. So everything will keep advancing and keep changing, and it's up to you to make sure that you are on the cutting edge. Also remember, you will learn lots more in your practice than you did in your residency training. Your residency training was just a good basic building block or foundation for the rest of your career, but you'll learn far more in the first few years of practice than you did in all of your medical training combined. And finally, probably the most important thing is remember to compete with yourself, not with others. I'm not in competition with any other surgeon. I'm in competition with myself. And that means I need to get better every case. Every week I need to be better. Just imagine if I could increase my surgical skill just 1% per week and compound that weekly. That's a humongous gain over the course of a year. And over the course of 5 or 10 years, it's just astounding. So your goal is to be better every single case, learn from every case. And the most important at the end of the day, give every patient your best. Give the treatment that you'd want to receive. Thank you again for 500 posts. CataractCoach.com. Successfully fixed this traumatic cataract and the mydriasis. So this is a patient who sustained ocular injury, and you can see there's the equator of the lens. And so we have zonular loss for quite a few clock hours. So we'll fill up the eye again with the balanced salt solution. You can see it goes back to position. And so let's try put some viscoelastic in to help create a barrier here, keep vitreous back. Now we'll make the main incision. Now this whole case is being done by a resident in training. So we got a nice capsulorhexis, slow and steady on the hydro dissection. And again, keeping in mind which part of the lens equator is the weakest. Where's the most zonular loss? We got the nucleus out of the capsular bag. We did some hydrodelineation there. So during nucleus removal, we want to minimize the stress that's placed on the remaining zonular support. So phaco probe is going to go inside the eye here. And again, anesthesia for this has been retrobulbar, so the patient's very nicely blocked. And the patient also received some IV sedation. So now the phaco probe goes in the eye, and this nucleus can be just chopped. And notice how the nucleus is at the iris plane. So that comes out pretty easily. Now, coming out of the eye, don't let the AC collapse. You don't want vitreous to come around that area of zonular loss. So that's why we're sealing the incision right now, keeping that AC pressurized. Here's a bimanual approach to the cortex removal. Now we still have not yet put on the capsular tension ring. We're going to wait to put that in until we remove most of this cortex. And so that looks pretty good now. You want to put the capsular tension ring as late in the surgery as you can. If you can put it after the removal of the cortex, that's easier. So a little bit of triamcinolone going in to make sure there's no vitreous. And that looks pretty good, just a little tiny bit, which we'll fix. And then now putting viscoelastic in, filling that bag, keeping that eye pressurized. So there's that little small piece of vitreous, which we'll get out later. Here's the capsular tension ring, just placing it in manually. And notice how it's threaded around very, very carefully, and we can get it all the way in, and there it is inside the capsular bag. Now the lens is going to be a 3-piece lens, and we're going to do something a little different here. We're going to place the haptics in the sulcus, and then we'll capture the optic behind the capsular rhexis. That's going to give us very stable and long-term support. So again, keeping the haptics in the sulcus, but the optic will be captured like a button through a buttonhole behind the anterior capsular rim. There it is. This is another reason why it's so important to have that 5mm capsular rhexis. Now that little bit of vitreous that's prolapsed, we'll get that, we'll take care of it. You can push it back out of the way. We can also use other instruments to cut that. So now we're bringing the pupil down. Remember, this patient also has traumatic mydriasis. And so we're going to bring the pupil down. We're going to examine a little bit more carefully here. There is that little bit of vitreous. So we're going to just hold it here and use micro scissors to just amputate that off. We don't want to do a big extensive vitrectomy. It's not needed. That was the only bit of vitreous that we had because we were very careful not to let more prolapse. So that looks pretty good. Now it's going to be time for the pupilloplasty. So let me show you that part as well. Again, this is the same surgery. Now we're going to reconstruct the pupil. And we'll use a simple technique. This is going to be the Agarwal 4th row pupilloplasty. So again, you can see very stable position here. Capsular bag is being supported by the CTR. And then now we're going to get some of the iris tissue here. We're using a 10-0 Prolene on this long needle, and then using a hollow bore needle to help pull it outside the eye. So we'll pass this through. There it goes, bringing out the paracentesis. And a couple pointers here. Don't pass the suture too close to the pupil margin. You need to grab a sufficient bite of tissue here. And then when we bring this loop through to the other side, now we can do the 4th rows. So bringing that loop outside the eye, just using a hook here, and then you can pass the other end, the loose end of the suture through 4 times. And once that's done, 1, 2, 3, 4. Again, this is Dr. Amar Agarwal's approach. It works quite nicely. And you can see we will then tighten the knot. The knot will go inside the eye, and we'll end up with a nice small pupil. Now, what's the goal for the pupil size here? You want a pupil size that's about 4 millimeters. Certainly 3.5 is about the smallest you want to go, because remember, this is not going to dilate again. And so we need to be able to examine the retina. So we place one suture, and you can see it looks pretty good, but it's going to be better once we place a few more sutures. So cut the ends of that off. Now the remaining suture passes are going to be done in the same manner. We can speed that up a little bit more. So we do one more to close this triangular defect, and that'll be sufficient for this side. And then we'll do a suture opposite in order to center up the pupil. And again, keeping in mind we want about a 4 millimeter pupil in the end. And then we'll bring that suture through, again the same technique. Now, this is going to give a very nice pupil size for most activities, and at conversation distance, when you're looking at the patient, you won't be able to tell the pupil slightly irregular from the sutures. It'll look pretty good. And then here comes the last suture to reconstruct that pupil, and you can see it looks pretty good. A very nice result. So this whole case with the traumatic cataract and then the pupiloplasty was performed by a resident in training with guidance, of course, from a professor. So you can certainly achieve the same results. So the key here is to know when to place the capsular tension ring, and the answer is as late as you can in the surgery, because it'll make a removal of cortex difficult. And then in the end, choosing an appropriate way of keeping the lens in good position, and then of course fixing that pupil. Thanks so much for watching. IOL exchange using the twist and out technique through a standard phaco incision with no special instruments. So the IOL is in the anterior chamber. One haptic is brought out through the unenlarged phaco incision. The edge of the optic is held with straight tying forceps. We'll use the chopper in the other hand to really get a good grip on that optic. There we go. Now using a spatula. The spatula is going to help protect the corneal endothelium and allow us to roll this IOL. So it'll assist in rolling the lens. We roll that optic around the forceps and then pull it outside the eye. Just that easy. And this even works down to a 2.4 millimeter incision with all single-piece acrylic lenses and even three-piece. Now, we've published this technique in the JCRS. The key is the hand positioning, starting supinated, then pronate, and keep rotating. Here's a resident performing the technique. We've sped the video up to 2 times normal, but this is a senior resident who's operating, doing the same technique. Again, holding the optic, spatula now is going on top of the IOL optic, protecting the cornea and helping to roll the lens. Now let's show you the external view. External views, the same thing here. Rotating to curl it up, and it can be brought outside the eye. Give it a try. Thank you. CataractCoach.com. Complete cataract case. Keys to cataract surgery efficiency and safety. I'm going to show you the full surgery from start to finish. There's the paracentesis. You can see the pupil looks pretty reasonable, maybe about 5.5 millimeters. Little anesthetics being placed in the eye. This is preservative-free lidocaine, cut 50-50 with balanced salt solution. That gives us a little bit more dilation, though it's probably going to be temporary. So when we put in our viscoelastic, here's the dispersive OVD. Let's try for some viscomydriasis injected at the pupil margin, and that will definitely expand the pupil. But remind you, that's temporary. Let's get that main incision done. So using a keratome here, temporal incision, single plane. Let's look carefully at the tunnel length. I like it. Slight tilting of the tip just to enter the AC. Very clean incision. Now it's time to do the capsulorhexis. So you saw that I just used the keratome, which is disposable, to incise the drape a little bit more so it didn't pool any fluid. So for this 5.5 millimeter rhexis, we want to be just about right at that pupil margin. So we're starting to tear that. We're going to trace this right along the pupil margin, and that should land our rhexis with a diameter between 5 and 5.5 millimeters. Notice the draping is good. All lashes out of the way, the lid margin sequestered. Nice red reflex. We've enhanced that by increasing the coaxial lighting. And look at the Purkinje images, no oil on the cornea. So very clean. You also notice that the incisions that we made do nick the limbal vessels. That means great long-term healing. I like it. So here comes the balanced salt solution, 27 gauge blunt cannula. We're going to do some hydrodissection here. I'm going to leave the nucleus in the bag. So there's a fluid wave, another wave. The nucleus comes up a little bit. But notice how we also lost viscoelastic. And the pupil did come down now when we lose that viscoelastic. So let's give a little extra small aliquot viscoelastic right at that central corneal endothelium. Not a huge fill, just a little bit. Here's the phaco probe. We're going to use a high vacuum, high flow setting, and we're going to chop it right there in the bag. So probe going in, I like bevel down. There's the chopper, so embed the phaco probe. Let's place the chopper in the nucleus, bring them together, and separate. There's 2 halves. Very nicely done. We can bring up each half and further sub-chop it. So for me, typical settings here are going to be a vacuum of between 400 and 500 millimeters of mercury, flow rate of at least 40 cc's per minute. We're going to have a high bottle height or an infusion pressure of at least 80 or 90 millimeters of mercury. Again, it's temporary. We're only doing this for about a minute for nucleus removal. That really helps keep the AC inflated and keeps the posterior capsule away, so we don't run into any issues there. So now we can take out those pieces. So about half the nucleus is already out. That looks great. Buzz into the second half, bring it up bring it to the iris plane, a little bit safer. You can see the pupil starting to come down already. This is a patient who takes Flomax or tamsulosin for his prostate issues. And that, of course, can cause some floppiness to the iris as well as a smaller pupil. So nice and careful here. Notice how we'll push this last nuclear piece in front and again, bring it away from the capsule and try and emulsify it right there at about the iris plane. And then we're using phaco power modulations. We're using a pulse mode here with a very low 30 to 40% duty cycle to really minimize the total energy placed in the eye. We want to give this patient a totally clear cornea on post-op day 1. And here come the last little bits. And let's clean up the rest with the IA probe. Now, a lot of people like to do the bimanual IA. I like it as well. But for routine cases, I tend to stick with the coaxial. You'll see here I'm using this special handpiece that can transform into a bimanual approach if needed. So there's a little bit of an epinuclear shell, aspirating that out. Now, you could have gotten that out of the phaco probe, but again, let's be on the safer side. Let's not take any undue risks there. So clean this up quite nicely. Now, we're keeping a mental track of where all the cortex is because you don't want to leave cortex in this eye. And it will check again at the end after I put the lens in. You'll check to make sure there's no retained lens cortex. So really cleaning up the capsular bag looks really nice. Take out some of this viscoelastic from the angle of the eye. And we're ready to fill the bag up with our cohesive viscoelastic and get the lens implanted. The lens is going to be a monofocal single-piece acrylic lens. And this patient's a little hyperopic, and so we're going to aim for a target of about plano for this patient. He was a +2 hyperop to begin with, and I think he'll be absolutely thrilled with this plano outcome. There comes the lens, leading haptic going in the bag. That's that 7L rule. If you don't know what that is, you better go to CataractCoach.com and look it up. That tells you about the configuration of the haptics to make sure they're correct. Let's open that haptic up. Now you can see that's a 6mm optic, so that pupil's probably about 4mm. So is it all okay? Is it in the bag? Well, why don't we check? Let's lift it up. Yup, in the bag, no cortex remaining. And we can do this for 360 degrees just using the chopper. And we can tell the lens is definitely in the bag and there is certainly no residual cortex in this eye. That's an important check. Now remove the viscoelastic and seal up the incision. Call this a day. This is a routine case start to finish. This is a very typical case for me in my operating room. I want to bring that to you. It's a pretty efficient case. Of course, speed is not my goal. I don't mind spending an extra 1, 2, 3, 5 minutes, whatever it takes. I want the best outcome, but I do want to be efficient. And the reason is I want to be minimally invasive. I don't want to have a lot of inflammation in this eye. And the longer the surgery is, the more time we spend in the eye, the more inflammation you're going to have afterwards. So if you can do a very brief surgery like this with a very minimal amount of phaco energy and good use of viscoelastic to protect that cornea, you can achieve a very nice outcome. You could have done it a different way. You could have put in a pupil expansion ring or something else to hold the pupil apart, but that would have caused a lot more inflammation. I think this is the better option. And certainly if you're one of the younger surgeons who are watching us, you can do this too. Stick with it, work hard. The world is your oyster. CataractCoach.com. Rock the nucleus with needle aspiration. This is for those milky white intumescent cataracts. So here's the cataract. You can see it's milky white. It's intumescent, so it's fluid filled. The cortex has liquefied. So we'll put in a trypan blue dye stain right here. That's great. Let's just fast forward a little bit. Diluting the stain now with our anesthetic injection. And then we're going to get a good fill of viscoelastic. We'll put a dispersive viscoelastic to really fill up the anterior chamber and pressurize the anterior chamber. We want the pressure in the AC to be a little higher than the pressure within the capsular bag. That's going to help prevent capsular runout and that dreaded Argentinian flag sign. So here's the viscoelastic going in. It's the dispersive agent. And we want to aim for a pressure of at least 30 millimeters of mercury. You can just judge that by touching the cornea. And now what we're going to do is switch over and we'll get a sharp 27 gauge needle on a 3 cc syringe, which is about half filled with bound salt solution. So that needle can also be slightly bent for easier access. Just make sure that it still flows normally. So there's the needle. we're going to poke into the center of the lens capsule. Right in the center, stab in, and you'll see as soon as we poke in, milk will come out. That's the lens milk, the liquefied cortex. And then we aspirate. And we can aspirate a lot of that liquid. Now, here's where you have to continue. So we aspirated some of it, but that's just the anterior liquefied cortex. There's more behind the lens nucleus. So to access that, we go back inside the eye, go in the whole opening we've made, rock the nucleus back and forth to release more of that milky fluid, and now re-aspirate. This has now really and completely depressurized the capsular bag, and we can proceed with the rest of the case relatively normally. And we've really minimized that risk of an Argentinian flag sign. Let's look at the diagrams. There's the nucleus, which is very dense. It's surrounded by liquefied cortex all around because all the cortex is liquefied. When we poke in with the needle, lens milk comes out because the pressure in the bag is high. And then we'll start to aspirate using that syringe, pulling back on it. We'll get out all that anterior liquefied cortex, and the nucleus then moves up and blocks the flow. So we need to rock that nucleus back and forth to help release all of the liquefied cortex from even behind the nucleus. Now the capsular bag is completely depressurized and all the liquefied cortex is fully removed. It's much easier to proceed with the case now. So now that we've removed all that liquefied lens cortex, we can make the incision here and do the capsulorhexis. So the incision is being made. We've of course sped up this video, and you'll see it's complete control during capsulorhexis creation. The resident's able to create a very nice capsulorhexis without any issues here. So grabbing here with the forceps, bringing it around, and there's no pressure to push towards the zonules like normally you'd have this rhexis wanting to run out because the posterior pressure of the nucleus due to the liquefied cortex that was trapped. But we removed all that. So now let's just fast forward to the end of the case here. Then the resident will chop the nucleus into many pieces and aspirate it down, and the rest of the case just goes beautifully. So this chop technique is very easy to perform in a white cataract because the visualization is great. The blue dye shows you the capsule edge, and then the nucleus is very white. Here's the end of the case, lens in the capsular bag. That looks great. This patient's going to be really happy. So remember, intumescent white cataract, rock that nucleus. And check out CataractCoach.com. If you're a resident, there's a whole section there right on the front page that gives you the key videos for every year of residency. 10 brief videos that'll make you a much better surgeon. Check it out. CataractCoach.com. Preventing the capsular rip. Approach to the highly pressurized white cataract. Let me show you what happened to the first eye. We poked in with the lens, and boom, it splits like that. Holy cow, we're in a world trouble. That's video 980 if you want to check that out. So now this is the same patient, the second eye. And it's the same thing. Look, when we touch that anterior lens capsule, oh my goodness, look how pressurized it is. The whole lens capsule is pressurized. The pressure in the capsular bag is much higher than the pressure in the anterior chamber. It's a white cataract, but there's no liquefied intumescent fluid. The whole lens is swollen. So we're going to buzz in with a phaco probe and create a central opening. Pow, right there. Now, ideally, you want this phaco probe to be almost aiming towards the optic nerve in the eye, very much aiming straight down so that you get a nice round hole in the lens capsule. So here, a little more viscoelastic being put in there, and we're going to buzz in with the probe, and oh, there's an opening. Oh my goodness, it's already ripping out. What should we do? Keep the phaco probe in the eye. That initial buzz was okay, but didn't create a perfectly round opening because the resident didn't have the round tip fully touching the lens capsule. But we have the infusion pressure set very high, a very high bottle height, infusion pressure of 95 millimeters of mercury. That's going to help. So we'll keep that phaco probe in the eye with one hand, and with the other hand, using a cystotome through the paracentesis to create some sort of small anterior lens capsular opening. Now, this does not have to be round. It doesn't even have to be centered. All it has to be is continuous. By making it continuous, it's not going to run out. It's not going to go out towards the nodular support. So if we can finish that up like this, that looks pretty good. Just a tiny bit left. Let's get some viscoelastic in there. Quickly get the forceps and quickly pull that centrally. Woo, we did it. Look at that. Okay, now we've got a kidney bean shaped opening. That's okay. Don't worry about it. As long as it's round or continuous and curvilinear, there's no edges that are going to run out. It doesn't have to be a perfect circle. It doesn't have to be 5 millimeters. It just has to be enough to be strong. Now we can go inside there using the IA probe. This lens is soft. It's not dense. And removing the whole lens just with the IA probe. Much better. Cortex removal coming up here. We can do a bimanual approach, which is going to be helpful because it's a small rhexis. This is not going to be the final rhexis. We're not going to leave it like this. But we want to clean up as much of the lens cortex as we can. So again, doing a bimanual approach is that transformer IA handpiece. Cleaning this up pretty nicely. That all looks pretty good. So once we get the IOL in the capsular bag, of course, then we can enlarge the rhexis. So cleaning up as best as we can here, a little bit of capsular polishing. You don't have to go crazy here. Just do a beautiful job. So filling up the bag, again, going in, trying to get out a little bit more of this lens material. But you know what? Let's just get the lens inside. So the IOL, of course, is going to be a single piece acrylic lens with a 6 millimeter optic. So when we get that lens inside the eye, here it comes. Deliver it, make sure it goes in the capsular bag. And now we can see that, okay, the rhexis, I will admit, is irregular and small. You could leave the case just like this and say, hey, it's okay, it'll be fine. And it would be. But we can do another step. Look at this. We can use our small scissors here to cut a nick in that anterior lens capsule. Use the forceps because the eye is filled with viscoelastic. There's a lot more control here with the IOL already in the capsular bag. And grab that, and look at that. We're going to enlarge that capsular rhexis. This is going to be a beautiful outcome. So what we did differently in this case is we used the phaco probe to, boom, punch a hole in the central lens capsule, aspirate out any of that the liquid that was there of the lens cortex. But more importantly, to set the infusion pressure 95 millimeters of mercury. So that phaco probe is in the eye. It helped prevent that high intralenticular pressure from causing issues. Now, there were suggestions on our channel of saying, hey, use a larger 18 gauge needle instead of the 25 or 27 gauge. It wouldn't have made a difference. There was an idea of using mannitol, intravenous mannitol. That would have dried out his vitreous, but it would not have changed the intralenticular pressure. So I think the best solution of all is what you just witnessed. Go inside, puncture a hole in the lens capsule with the phaco probe. Hopefully it'll be round. Keep the infusion pressure up and get a baby rhexis done first. Take out the cataract, and then you can enlarge the rhexis. CataractCoach.com. 1 year since COVID. And what are your priorities? Out with the old, in with the new. 12 months. It's been a full year since the start of the pandemic. And it's changed us all profoundly. It's affected us personally, professionally. And looking back on the last year, I asked myself, what was its impact for me? On a personal level, it really did cause me to reprioritize my goals, redefine success. Looking at this graph here, the old way of measuring success probably wasn't the best. The new way, we emphasize a lot more of the health aspect, mental health, physical health, exercising, getting out there, enjoying time with our family, prioritizing those relationships, enjoying our free time, and maybe income and job title and surgical volumes, not that important. So it's basically finding balance in life. And that was helpful to me. A lot of introspection during this past year. On a professional aspect, first things first, the mask, right? We're used to doing universal precautions for bloodborne pathogens, needle precautions and sharps, but we now do that for respiratory. So respiratory precautions are now part of the norm. And I think even the post-COVID times, There's no need to be a foot away from the patient at the slit lamp without having some sort of respiratory protection for both the patient and for the physician. So I think that's going to be incorporated. We also learned that our team members at work, they're more than just work. They're family. We learn to take care of them. Even during the tough times, we take care of each other. We've got to learn to weather the storm together. And then finally, I really missed the in-person meetings. Being able to meet colleagues and learn more ophthalmology at these large international local meetings. But we're getting close. We're doing now online streaming. In some ways, it's even better. Like Amazon or Netflix, we can stream anytime we want just the topics we desire. My own personal horse in the race is CataractCoach.com, where there's a new video posted every day. They're all 5 minutes and 1,000 videos already, and you can choose any topic. So I think the COVID impact for us has been big, personally, professionally, but I think we've all weathered the storm together, and I see bright sunshine coming up ahead. So hopefully everything will get back to a more reasonable style of life. Thanks.